The moment a surgical scalpel breaches the skin barrier, the patient's internal environment is exposed to billions of commensal skin flora. Without an immediate pharmacological shield, these bacteria swarm the incision site, triggering a surgical site infection. Preventing these infections demands strict pharmacokinetic alignment. The drug must reach its maximum tissue concentration at the exact moment the first cut is made. This flowchart illustrates the 5-pillar global evidence-based bundle, a unified protocol for perioperative antibiotic management. The primary objective of this protocol is to achieve a bactericidal tissue concentration prior to the incision and to sustain that level continuously through closure. Equally critical is the secondary objective, halting the antibiotic administration precisely before antimicrobial resistance has a chance to develop. Executing this exact timeline algorithmically drives down surgical site infection rates while simultaneously suppressing the risk of multi-drug resistant organisms. Mastering these 5 pillars shields the patient from both acute operative infection and long-term antibiotic toxicity. The first pillar is pathogen-specific agent selection. For standard risk prophylaxis worldwide, cefazolin is the gold standard. This matrix outlines the rigid late-base dosing requirements. For standard risk patients under 120 kilograms, a 2-gram intravenous dose of cefazolin is required. For patients exceeding 120 kilograms, the dose increases to 3 grams. If the patient has a severe type 1 beta-lactam allergy, the protocol shifts. The alternative dosing parameters specify vancomycin at 15 milligrams per kilogram or a 900 milligram dose of clindamycin. Surgeons must avoid the routine use of topical antibiotics in the wound bed. Clinical data shows these applications offer zero measurable reduction in surgical site infections. Pathogen-specific, weight-optimized agent selection equips the patient with the exact pharmacological armor required before they ever enter the operating theater. Timing the infusion is just as critical as the dose itself. Administering prophylaxis more than 120 minutes prior to incision increases the risk of infection 5-fold. Administering it after the incision doubles the risk. This timeline graphs infusion kinetics against the moment of incision. For short half-life agents like cefazolin, administration must begin 30 to 60 minutes prior to the cut. As shown, cefazolin achieves its peak bactericidal concentration exactly 40 minutes after intravenous administration. If the surgery involves an extremity, the full volume of the infusion must be entirely completed before any tourniquet is inflated. Otherwise, the drug will never reach the distal tissues. Long infusion agents like vancomycin fall in different protocol. They must be initiated 60 to 120 minutes prior to incision to ensure the 1-hour infusion process completes before the scalpel drops. Aligning these infusion kinetics with the surgical countdown ensures that peak bactericidal levels are active precisely when the skin barrier is breached. Once the operation begins, the carefully calculated baseline can be rapidly destroyed by massive surgical blood volume shifts. Initiating cardiopulmonary bypass alters the patient's volume of distribution as the blood interacts with the artificial circuit. This graph demonstrates the resulting pharmacokinetic crash. As hemodilution accelerates renal clearance, the blue line representing serum antibiotic concentration drops precipitously, falling below the red dotted line representing the minimum inhibitory concentration. Anesthesiologists execute the 2 half-life rule to rescue these serum levels. Because cefazolin has a 2-hour half-life, it's redosed exactly 4 hours from initial administration, not from incision. This pushes drug levels safely back above the threshold.
There is a strict exception to this timer. Immediate redosing is mandatory at any point if intraoperative blood loss exceeds 1,500 milliliters. This proactive intraoperative redosing prevents the patient's antibiotic shield from shattering under the extreme physiological stress of major surgery. Extracorporeal membrane oxygenation introduces a pharmacokinetic anomaly that completely defies standard weight-based dosing rules. This diagram illustrates why. The ECMO machine's artificial polyvinyl chloride circuits massively expand the patient's volume of distribution. The circuit actively sequesters lipophilic drugs, absorbing them directly and stripping them from the serum. Blanket dosing protocols fail completely in this environment. Because of this extreme sequestration, routine systemic prophylaxis in ECMO patients currently lacks robust data support. To prevent severe subtherapeutic dosing, precise therapeutic drug monitoring is an absolute requirement. Heart transplant patients face compounding risks. Intense immunosuppression dictates specific multimodal prophylaxis tailored to local antibiograms to cover bacterial, fungal, and viral threats. Artificial circuits and extreme immunosuppressive interventions require clinical teams to abandon static protocols in favor of dynamic, patient-specific drug monitoring. Once the operation is closed, teams face a globally persistent yet dangerous post-operative practice known as the discontinuation fallacy. Many surgical teams operate under the assumption that the presence of intrathoracic or surgical drains justifies continuing systemic antibiotics. This is a myth. This chart tracks post-operative antibiotic duration. The blue bars representing surgical site infection rates remain entirely flat from 4 to 48 hours. Extending administration provides zero additional infection reduction. But as exposure crosses 48 hours, drug toxicity and Clostridioids difficile risk begins a sharp climb. By pumping unnecessary antibiotics into the patient, the care team actively accelerates the selection and mutation of multi-drug resistant organisms within the hospital ecosystem. The clinical mandate is clear: manage surgical drains mechanically and clinically, but terminate the pharmacological interventions at 24 hours. Establishing a 24-hour hard stop functions as a patient safety mechanism, preventing the selection of secondary hospital-acquired infections. While these protocols are rigid for cardiac and high-risk procedures, strict divergences exist in non-cardiac fields, particularly within orthopedics. This graphic outlines the orthopedic divergence. Notice the crossed-out link between the dental drill and the joint. Routine systemic antibiotic prophylaxis is not recommended for dental procedures in patients with prior total joint arthroplasty. Instead, protocol mandates delaying elective dental procedures until 3 months post-arthroplasty. The physiological rationale is precise. Transient bacteremia from dental work clears from the bloodstream in minutes to hours. Administering antibiotics in this scenario does not lower the risk of joint infection. It only elevates the patient's risk of resistance. Regardless of the discipline, the ultimate execution of the global protocol requires strict procedural standardization in the operating room. This checklist is the anesthesiologist's heads-up display. First, verify the agent based on allergies and optimize dose by patient weight. Confirm infusion kinetics are aligned, reaching 100% before incision. Finally, set the 4-hour intraoperative redose timer and lock the strict 24-hour hard stop. Mastering these 5 pillars ensures the pharmacological shield remains intact throughout the surgical window, guarding against infection without fueling long-term resistance.